Hello everyone. So today again I have came up for you all with a very good case that is not that uncommon in our country or across the world also. Today we will discuss something about hypertrophic obstructive cardiomyopathy. Now, it may happen many times that you are sitting in your OPD or your college or something like that. Suddenly, a patient is been brought to you with a history of sudden onset palpitation, sudden onset anxiety, chest pain, or many times sudden death too. When you see the patient is thin. There are very less risk factors associated with the heart disease when you take proper history. But then too, why the patient would die suddenly while playing games like basketball, cricket, football, as we see these days on social media, that a very healthy appearing person suddenly dies while playing cricket, football, volleyball, etc., running, etc. Why should an athletic person die suddenly? So, we should not forget that many times these are associated with the condition called as the hypertrophic obstructive cardiomyopathy. Now, as the name suggests, it is hypertrophic obstructive cardiomyopathy. This is very common, equal between men and women, and usually it is hereditary in origin, most commonly an autosomal dominant pattern. This is associated with mutations in the sarcomeric genes like beta myosin heavy chains, actin, titin, troponin, etc. What happens in hypertrophic obstructive cardiomyopathy, which many times can be non-obstructive also, but there is a hypertrophy of the left ventricular muscles commonly, and in that too the most common pattern is interventricular septal thickening. So the normal wall thickening of the left ventricle roughly is between zero point 0.9 to 1.2 centimeters, which we will see in the echo also today on a live patient that is admitted, who is admitted under me. So what happens in hypertrophic cardiomyopathy? Your left ventricular walls are very thick. So whenever the heart beats, the mitral wall, especially the anterior mitral leaflet, while it is opening and closing with each heartbeat, it gets impinged or it gets stuck to the basal interventricular septum. Hence the blood that flows out from the left ventricle during systole through the aorta gets obstructed. So in hypertrophic obstructive cardiomyopathy or HOCM, now I will call it as HOCM to save time. So what happens in HOCM? There is a dynamic obstruction to the LVOT flow. Why it is dynamic? Because it is associated with the moving heart, or I should say it is associated with an obstruction during mid or late systole. Whenever the heart is trying to pump the blood out from the aorta, the mitral valve is getting stuck to the left to the interventricular septum, hence closing the left ventricular outflow tract, and hence there is outflow obstruction. In this process, what happens when the mitral valve is getting stuck to the IVS? There is some blood that is also coming back to the left atrium because it is not getting closed properly through the mitral valve. So there is a small gap which is remaining, and some blood during systole, since it is not able to go out from the aorta, some blood flows back to the sorry, to the left atrium. So mitral valve regurgitation, especially a jet that is directed posteriorly, which we will again see in that patient today, is very common in hypertrophic obstructive cardiomyopathy. Always remember that hypertrophic obstructive cardiomyopathy is also associated with diastolic dysfunction, which again we will be seeing in our patient today. So what happens? The heart is not able to fill properly during the diastole, and remember, the heart muscles, the myocardium, it receives its blood because it also needs blood for functioning properly, no? So the heart muscle receives the blood during diastole only. So if the heart is not able to fill during the diastole, how can the muscle get the proper blood supply? Hence Many times the patient of HOCM will present to you with myocardial ischemic symptoms, and when you do a coronary angiography of these patients, most of the time it is normal. Why? Because it's a functional ischemia. It is not because of a block in the arteries, but it is because the heart itself is not getting filled during diastole, because there is a diastolic dysfunction in HOCM. Remember, the most common variant of HOCM is asymmetrical septal hypertrophy, but our patient that we will see in the upcoming time is having a symmetrical hypertrophy of whole left ventricle with interventricular septum as well, because of which we will have a dynamic alveoli obstruction. So usually it is seen that that HOCM is also associated with some sort of catecholaminergic surge, which is also thought to be one of the cause of causing this pathology. Many times the coronary arteries in such disease, they are stiff and they do not dilate during proper diastole, hence can lead to many pathological symptoms that the patient comes to you with. Remember, such patients commonly complain of palpitation, syncope, pre-syncope, a history of sudden death, or a history of sudden death in first degree relatives, etc. So you should always take proper history in such patients. The patient that we are going to see today, he has 7 brothers and few sisters, 1 or 2. So I have called all of them within a week, so that I can screen them as a whole to see whether any brother or sister of this patient has got HOCM or not. His father is also going to come, and their children are also going to come, the patient's children and all. So we'll screen everyone, because this will run in family. As I said, it is inherited as an autosomal dominant form. So when we come to the treatment or the maneuver that can help you, remember, whenever you are clinically examining any patient of HOCM, you can get a double carotid impulse, you can get an enlarged heart, or you can get the apical impulse that is displaced down and out because of the left ventricular hypertrophy. But remember, whenever you are auscultating such patient, always try to hear for S4, because we know that S4 is a finding of a straining heart. So here in this case the heart is straining, so the patient can have S4. The patient can have features of cardiac failure, or many times the patient can have a faint systolic murmur at the mitral area, which is nothing but the murmur of alveoli obstruction. So you should always pay attention whether the patient have such kind of findings or not. Remember, 25% of the patients of HOCM can have obstruction, dynamic significant obstruction during rest. But remember, 70% of the patients will have a normal gradient through the alveoli at rest, but you can provoke a dynamic alveoli obstruction in such patients with certain maneuvers. Which are these maneuvers? These are the maneuver which will reduce the preload and the afterload, like a Valsalva maneuver. If a patient has came to you with features of HOCM or hypertrophied heart, but the gradient through the alveoli is normal, in such cases you can ask the patient to perform a Valsalva maneuver. The Valsalva maneuver will decrease the preload and it will aggravate the alveoli obstruction. Similarly, if you make the patient stand up, it will again decrease the preload, and the patient can present to you with a dynamic alveoli obstruction in such cases. Avoid giving drugs that will decrease the preload and afterload, especially nitrates and ACE inhibitors. You should always pay attention that you don't give nitrates and ACE inhibitors to HOCM patients, because it will aggravate the pathology. Beta blockers and calcium channel blockers, cardioselective calcium channel blockers, are the safest drugs and the first line drugs that you should always give to such patients, because beta blockers will do what? It will prolong the diastole, so it will give time to the heart to fill properly, so that the heart muscles get proper blood supply. Similarly, you should educate the patient not to do strenuous exercise, not to do or involve in strenuous sports, so that you can avoid the death of such patients. Always remember, these patients die commonly not because of the alveoli. Yes, it is pathological, it is fatal, but commonly HOCM patients will die because of arrhythmias. Our patient, which we will be seeing later in this lecture on 2D echo, he had 90% arrhythmias over a period of 2 days when we did his Holter for 2 days. So he is proven he is at risk. The treatment of such patients is implantation of an AIVD that will prevent or defibrillate a patient if he lands up with fatal arrhythmias. So patient will have complications like arrhythmias, especially VTACs, especially atrial fibrillation. Patient can have cardiac failure, patient can have myocardial infarction, patient can have endocarditis of the mitral valve, patient can have thromboembolic episodes. So always remember, you educate these patients not to involve in strenuous activities. Try to give beta blocker to these patients, and if possible subject the patient for surgical myomectomy, alcohol ablation, or you educate the patient to get implanted the AIVD so that they can be saved from fatal arrhythmias. So this was in short, not exactly short, it was a heavy lecture for you all, but these are the things that we should know regarding hypertrophic obstructive cardiomyopathy. So let us go to my cardio lab, where we do echocardiography of such patients at our medical college, and see what are the echocardiographic features that we can get in such patients. Let us go there. So after the brief discussion on the so-called theoretical part of HOCM, let us see the patient live. We have this patient from Madhya Pradesh who accidentally presented to us with history of palpitation. As I said, this could be one of the symptoms, and he had anxiety, syncope like symptoms. So we did the echocardiography and found that he is actually fitting in the criteria of HOCM. So let us see his echocardiography live. So if the cameraman can come and focus on the echo machine. So we have this 25-year-old male. As I said, HOCM patients will have severe hypertrophy of the left ventricle. Specifically, the interventricular septum, as you can see, is very much thickened. If I pause this video and just try to show you the thickness of the ventricular septum, interventricular septum, see. His interventricular septum is nearly 25 millimeter in diastole. Although this can occur in the whole left ventricle, but commonly the interventricular septum is more thickened. If you pay attention to the mitral valve, this is the anterior mitral leaflet that we can see in the heart. See, while beating during the systole, this mitral valve is touching the interventricular septum, and because the interventricular septum is anterior in orientation, this motion is called as the systolic anterior motion of the mitral valve leaflet, specifically the anterior mitral leaflet, which blocks the LVOT during systole. As you can see, this mitral valve is touching the septum and it is blocking this aorta. This is the aorta. So when the heart contracts, this blood is coming out of the aorta, but because this anterior mitral leaflet is sticking on the interventricular septum during systole, this heart cannot beat properly. So this is the systole, and this way is blocked by the anterior mitral leaflet, which is sticking on the hypertrophied ventricular septum, and hence the patient may have symptoms like syncope. So if I start this picture again, so this is how we measure the interventricular thickness, and we see the anterior motion of the mitral valve. See this it is touching the, see, this is the systole. So heart has started contracting and this mitral valve has stuck to the interventricular septum. If I show you the 4-chamber view of this patient's heart, see, this is the 4-chamber view. So everyone can easily make out that the heart is abnormally thickened, more than what we expect in any subject. In a normal subject, the left ventricular wall thickness should be around 0.9 to 1.2 centimeter range, but this is more than 25 millimeter, as we saw. In the 4-chamber view, see again, during systole, this mitral valve is sticking on the interventricular septum, and since the blood will come from the left atrium to the left ventricle, and from the left ventricle it will go out through the aorta. This is the aorta in 5-chamber view, but this way, this route is obstructed by this mitral valve. The patient will have this obstructed mitral valve or the route. So if we put a continuous wave Doppler, see, we cannot use the pulse wave Doppler because it will not help us in detecting this high gradient. So if I put this continuous wave Doppler, we get this dagger shaped LVOT outflow, which is very classical of HOCM. So I have recorded one of the windows for you all. So I will just show the cursor button is where, yes, this is the cursor button. I will just show you. I have recorded this. So this is the patient's left ventricular continuous wave Doppler flow, and when we measure this, see, automatically we get something which is in the range of, if you can just come closer and show the value to the viewers, this is 68 millimeters of mercury. The gradient across the LVOT is 68. So whenever we have a patient of HOCM and this LVOT, left ventricular outflow tract obstruction, is more than 50 millimeters of mercury, it is considered as severe LVOT obstruction. So this patient has a severe left ventricular outflow tract obstruction, because of which he is symptomatic. Moreover, one thing that I would also like to show you is, patients of HOCM commonly have diastolic dysfunction. So if I put pulse wave Doppler, we clearly have this patient having this grade 1 diastolic dysfunction. Now we know that the heart muscles, myocardium, receives the blood in diastole. So if the ventricle is not filling properly in diastole, there is insufficient blood supply to the myocytes, to the myocardium, as a result of which HOCM patients can also present with myocardial ischemia, like this patient did. This patient presented to us with a chest pain, with high troponin I levels, but incidentally we found this patient to have syncope, to have palpitation, and to have HOCM. His coronaries are normal, but his myocytes are not getting proper blood, because there is a diastolic dysfunction because of the HOCM, as a result of which he had this non-ST elevation MI. If we can again focus on the windows, this patient has hypertrophy of the right ventricle also. This is the right ventricle, so this is also hypertrophied, and this is the left ventricle, which is clearly hypertrophied with a systolic anterior motion of the mitral valve. Every one of you can make clearly that this mitral valve is sticking on the ventricular septum during systole. This is the systole of the, this is the diastole, this is the systole. During systole, it is getting stuck to the interventricular septum, and if we put a color Doppler at the mitral valve, the patient will also have small amount of mitral regurgitation. Why this is happening? Because as soon as in systole, as soon as this mitral valve is getting stuck to the ventricular septum, the mitral valve is remaining opened, so blood is pushed back to the left atrium, because instead of sticking together, the mitral valve is getting separated, because it is getting stuck to the interventricular septum. So there is a room for blood during systole to come back from the left ventricle to the left atrium, as a result of which we have a posteriorly directed jet of mitral regurgitation, which is a common finding in HOCM. The treatment, as I said, it would be a septal ablation or an alcoholic ablation, etc. But since this patient also had symptoms of arrhythmias, this patient was subjected to Holter monitoring, and this patient had 90% atrial arrhythmias when we did the Holter monitoring for 2 days. So the ideal treatment for this patient as of now to save his life would be to put AIVD or a ventricular defibrillator, which is no doubt for us as Indians a bit of expensive treatment, but we'll have to do it to save the patient. So I hope this video and the previous lecture on HOCM would be useful for every new doctor, every senior doctor, every of my colleagues, and you would find it useful. I hope this might have made HOCM more clear for our fellow friends. Thank you so much.